You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
It's all good. We're here.
Well, thanks for doing this. Appreciate it.
Hey, listen, I love this conversation. I think the papers that we discussed, most importantly, Shaw's paper would be a good one to review if we really want to go through, the old and more contemporary ideas. But I mean, something I've been thinking about a lot over the last couple of years. So this is a great opportunity to discuss it.
Yeah. Let me pull up. So this is my latest copy of Shaw with all my, I don't know if you can see all these tabs, but so that's what kind of spurred this. Was I was doing this review of this article for the residency, and then just my two kind of questions that I've been asking everybody is like, why do you think joint restriction exists? And then, are trigger points real, quote unquote? And then what would you do with either one of those answers, right? That kind of shapes how you treat. And because Ben Stevens, I asked him that question. He's like, I don't care. I'm just going to treat him. And I was like, yeah, I know. And he goes, yeah, I get what you're saying. He goes, you kind of always want to be thinking about it, but it still doesn't matter. It's like, I don't know, maybe. So I don't know the best place to jump in because honestly, I had a little like freak out moment last night because I was like, I had read like half these articles he sent me. And then I was like, I looked at Sloan, I was like, I'm sequestering myself for the next hour to 2 hours. I'm going to just like make sure I read all these fully. And then I put all of those articles that you gave me, which anybody listening, I'll put all these in the show notes. I put them in chronological order, which some of them won't make sense because they're on a little bit different topics. But I thought that was the way to go about it because the Quinter article and then the rebuttal to it and then things that came out before or after kind of shaped this whole conversation. And like most of my podcasts, I just jumped into this. So if you're listening, what we're talking about is I asked Steve Capobianco, who's here joining me. If you don't know who he is, I'll do a fancy intro after this talk. But you should, because this is the third showing on my show. He's well known within our field and just a great guy overall that we got to share a great meal with in Austin. And that's the first time I've seen you in a while. So that was great seeing you, man.
It was great.
But this convo was shaped around what is actually going on, which it just seems crazy to me that the amount of conjecture around, I wouldn't say simple stuff, because obviously it's not simple. There's still it's a lot of theory, multiple theories, but it's like crazy that like entire systems are based upon these things we're going to talk about. Entire professions are based upon these things. And then at the end of the day, we're like, hell, some people say it doesn't exist. Some people say it does, which kind of sounds like subluxation or other things. So what we're talking about is trigger points in particular today, and then we'll kind of tangent off into just, soft tissue myofascial work, and then a little bit of what you're working on in terms of your approach. So the first jump in point, let's use the Shaw article, because in my opinion, I mean, you know better than I do, I think that's a pretty comprehensive review of the literature, that even though it came out in 2015, some other things have come out since then. I don't want to say, what's your opinion on this, but where do you stand as both the literature would state and then also what you've just seen over, the course of your, career? Because as much as we hate to throw the baby out with bathwater, that matters too. So.
Yeah, it really does. And I mean, when you kind of sent the paper along, it's something that I've read through Shaw's paper. I can't tell you how many times, and mine is equally as carved up. And I use sticky notes, and I have my similar little tabs that you do as it, to organize, the thought process, because it's complex. It's not complicated, to be honest, if you really start to dive deep into what we're trying to achieve as a manual therapist. And you brought up Ben Stevens and others in our field, and in manual therapy in general. The treatments of these hypotheses are relatively similar. They haven't changed that much in my opinion. I've been in practice 21 years, moving on to 22. But we're talking decades, multiple decades, where treatments are relatively similar to what they used to be. So it piqued my interest when you brought this back to my attention and started to get me to think what's been my evolution as it relates to a manual therapist, taking the ideas that we've been inundated with, as at least in the chiropractic field, talking about something similar like the subluxation when it comes to the spine. And so I really I took the opportunity. I could tell you, my family noticed yesterday as I started to kind of uh, condense my thoughts into hopefully something that I think we could communicate today effectively. But if I had to answer the question, I've gone through the spectrum from the classic mechanic reductionist view of like I'm beating on a muscle, and that was fed to me from our formal education, which I thought was amazing, to be honest, but reductionist nonetheless. And we should talk about that, and we should just kind of go through point by point as it relates to this myofascial trigger point, if we're discussing that entity of how just the definition alone is reductionist, and it made me a very good mechanic, meaning that I knew what my target was. My patients and clients knew exactly what we were trying to attack, and it was, for a lack of a better term, this is important to bring up, and is that I think that I was effective, effective
Mm-hmm.
at least in the short term, right? And so that's kind of where I started off, was that traditional mechanic, and but as I started to evaluate even my own philosophies over the last 21 years, specifically as it relates to the last 10 or 15, my mechanic mindset is moved into this, what I call this holistic or humanistic approach, which is also in this paper. And so I'd like for us, if we could, kind of talk about kind of that evolution of the reductionist view to this holistic view that were brought up really well in this paper. And I think it's a
Mm-hmm.
good, like you said, a launching board for us to discuss.
Yeah. So, and again, I did. It's just a solo review for me, just to bring this up. So again, if you're out there watching this and we're talking about this paper, I did a review of this article, which is just me going over the highlights of it. I'm not like drawing opinions. I'm just kind of pointing out what I thought was interesting. But also just
Hmm.
look up the article for yourself and read it. That's
Yeah.
half the battle in our field, is getting people to come to their own conclusions. But hopefully, those conclusions are based on principles and other information. And I think everybody is entitled to their own opinion, as long as that opinion, I hate to use the word justified, comes from a place that can be substantiated by other evidence, or a long-term anecdotal approach from practice. So diving into this article, as you said, kind of the first things that it does is define a trigger point, which I
Hmm.
would assume that most people listening to this would know some semblance of a definition. But basically, pick your poison. Everybody dances around the same thing. You have a taut band, a tight part of a muscle, whether that's all of it or some of it, with then a palpable nodule within it that can be palpated. Now we can talk about Interrater reliability on that,
Yeah.
picking it up with other technologies, which I know we'll get into. And then you get into the pain mechanisms along with this manifestation, within the tissue, of both local pain, maybe a latent trigger point that doesn't have active pain, but then has pain on palpation. Then of course referral patterns. Then the referral pattern stuff itself is just kind of crazy to me. I'm gonna switch cams here because this is gonna go off on me. Sorry.
No worries.
Come on. Maybe it won't let me. All right. Um, so that's our classic definition. And what kind of blew me away in this paper was how long ago people were talking about this, right? Go back to, the 1500s, and which makes sense. I mean, people have been doing body work for thousands of years, maybe much longer than that. We find out that, things are, much older than we originally hypothesized. So if we're talking about that manifestation of this, let's talk about the physical entity, right? And we're talking about the things that we were taught in school. We were taught, depending on where you went, different techniques or methods, but how to palpate, how to manipulate joints. But then for the most part, everybody got some sort of soft tissue technique, whether that was an ancillary class that you had the option to take or something you did outside of the curriculum. So what's our first dive in with, okay, we have this thing that a lot of people are saying is present. This is the crazy thing that some people say it's not at all. And we are taught to feel these things, to palpate these things. So what does that mean when we find this thing? Is it the first thing to dive into, is this a purely physiologic thing? Is this a neurophysiologic thing? Is this the humanistic, a psycho-emotional neurophysiologic thing? What's the kind of spin on that?
Just listening to you talk about it and talk about the breadth of just the conversation, and maybe you and I are, incorrectly inflating this conversation, but I really think it's important for most manual therapists. I think the polarization, we're in an election year, and I swear we're going to come back to our conversation. You know what I mean? But the point is, in this election year, everything is heightened. The conversations are heightened in respect to opinions on both sides of the fence. And I don't want to get into that conversation today, but there is equal polarization. And my gosh, if we're talking about something that's polarizing in our industry or manual therapy, the industry of manual therapy, a trigger point is highly contested as it relates to, do you believe in it or not? And so let me just start with my viewpoint in it is that the phenomenon is real. And the reason it's real is that patients come to us, and the ones that we are serving, they're coming to us telling us that they have a tight knot, a band. They've been educated, and I'll use that with quotations, obviously, when it comes to Dr. Google, and indicating that they have a myofascial trigger point, that they don't even understand what that term means for the most part, but they're coming to us with this entity. And so the phenomenon is real. What people feel, and we could talk about, the idea of what we're learning about pain science, but the expression, the experience is real. So we have to take it very seriously because the person's coming to us for help. We can argue, and the paper does a great job, and any of the listeners here can do their own due diligence and read through and look at the arguments for and against the physiological entity or phenomenon. Is it something that we can actually find? Is there reliability when it comes to our hands to be able to touch and feel these top bands, these hypersensitive nodules, etc.? And we should get into that conversation. But to start off with, the phenomenon is real, and I don't think anyone should argue that fact, because people come in feeling these sites on their body that are causing pain. I think the concern is that with a definition as laid out by ultimately Travell and Simmons or Simons, depending on how you pronounce it, the reductionist view of it, saying that it's a muscle or in the muscle tissue, requires a different approach to be able to attack it. And depending on your level of understanding, that approach could be, I'm going to be using, and I'm not sure if these are going to be on screen or not, but using a myofascial ball, a foam roller, a handheld stick, or a therapist elbow. We need to attack this tissue. The enemy is in the muscle, so I need to attack it. And depending on where that muscle is located, and I always kind of target the conversation around the psoas, because it's the ultimate enemy when it comes to the lower back, as you probably have already recognized in your career, that people come in with notions saying that it's my psoas that's causing my back pain. I have this hyper, sensitive area, and I want you to go and attack it. I've been, attacking it, speaking for the patient, for weeks or months. And some people, literally bruising themselves to get to the tissue. And that, to me, is the first problem that needs to be kind of understood, is what are we really addressing here? What do we know now compared to the 80s and 90s, when Travell and Simmons came out and said that this was in the muscular tissue? should that be part of the conversation? Are we talking, I'm going to use, Phil Snell's uh, verbiage, which I love because I love that man, is that he always talks about that mesodermal concept versus the ectodermal concept, which I communicate in my education as well, because it matters. If we're identifying this tissue as the issue, then we're going to go and attack that tissue like in a mechanic. And patients are most vulnerable to this idea that if it's muscle, I need to attack the muscle, and they're going to do so like a mechanic would.
So, okay. And again, the reason that this conversation is like a bicycle wheel spinning with paint all over it is because there's so many places to dive in. The phenomenon, and then like we're gonna go through all these, and I was kind of writing a path as we kind of let this start. Is like, okay, we're talking about this physical phenomenon, which obviously you keep alluding to. Is it in the muscle? So then we kind of need to. I think that what we have to go after right now is, okay, we know that people are coming in complaining of tight bands, a muscle. Maybe they even provided themselves temporary relief by smashing with a lacrosse ball. They create referral patterns, right?
Uh-huh.
Working on it, and they're like, hey, this shot down on my foot, and I feel that foot pain when I hit 3 miles, but I was working on my hip. Like, people do all the things where you're like, yeah, I know what it is. So there's this physical manifestation, but then from a hypothetical standpoint, the next step is, okay, they're real, right? What's causing them? And this is the huge, swath of, I mean, right now I'm looking at 7 different hypotheses over the course of the last 50 years.
Yeah.
And I'm sure there's more.
Mm-hmm.
And, then those hypotheses play into motor control hypotheses and pain science hypotheses. And they all kind of start creating this tangled web of like, it's going to come down to the in question, which we'll get to towards, the wrap up of the podcast, is how much does it matter? What you were alluding to of, I was effective dropping an elbow in somebody's glute, maybe because the clarity of the message, which I don't want to get too much into that now because we'll get into it later.
Mm-hmm.
But from a hypothetical standpoint of cause, I could summarize like Shaw did, that when you look at most of these hypotheses, there's some sort of concept of work that's being done by the muscle, subthreshold nociceptive input, right? You're kind of working at this level where the muscle's not being damaged, right? It's not working too hard, but you're doing something. And, the classic example is the assembly line worker. You do the same thing over and over, and that muscle kind of gets worked. That kind of exists in a lot of these theories. Now, is that completely true? I don't know. It's a theory. But then the thought process plays into, okay, now is it purely in the muscle, or are you kind of ringing the bell at the spinal cord? Well, then when you ring the bell at the spinal cord, are you now ringing it, in the central nervous system? And now you have both opportunities for peripheral and central sensitization.
Mm-hmm.
So again, coming back to you, because the reason I want you on the show is I want your opinions on this information. What do you is there a predominant theory? Do you have kind of your own ideas that you've amassed from all of these concepts? Where do you stand on that?
Yeah, great way to kind of organize it. To your point, and I listen. Your listeners know this. If anyone is listening to conversations like this, because we're looking for insight to be able to kind of organize our thoughts, because it is complex, and we all understand this. I don't think it needs to be reaffirmed again and again, but we're talking about the human being, and this mechanistic view that, at least that I've been trained with, because I've been in practice a little bit longer than you, and so that my training was a mechanic, and so I focused my attention on what I was taught, which was looking at this tissue, just like Phil would say, the mesoderm, to address dysfunction. But what Shad did a great job, in my opinion, and I organized it in respect to 4 different theories that I think we could discuss, and that's how I organize it in my brain. But interesting enough, as I describe these to you, it does take you on a road trip along with my mindset or my philosophy over the last 20 years. So let me just kind of bring it to your attention. I wrote it down, so just excuse me for looking away. But the first one was as it relates to, and this is in the paper, so using the words that Shah would use, or Shah and colleagues, would be the soft tissue milieu. First and foremost, I just love saying that. But secondly, I love that conversation of starting the expansion, and this is what I would use the term the extracellular matrix. The Shaw in this paper uses the term the neighborhood that the muscles live in, and I can't tell you how cool I think that concept is, and I'm going to steal it. I'll obviously give him credit, but the idea of the neighborhood of tissues and environments that the muscle is bathed in is now at least with this group, and we're starting to see it in the fascial research group, as let's look at this network of tissue that the muscles live in. We're not 600 plus muscles, but Tom Myers would say we're one muscle in 600 bags that are encapsulated in this fascial network, this soft tissue milieu. And so that is like the first thing that I think we should discuss, is that the expansion of the tissues that we think that we're interacting with, and why that matters, in my opinion at least, is that it pulls away from the mesoderm, meaning I'm just attacking the muscle and it's got to be in a tight band of muscular tissue. And maybe we should be discussing, as the Stecco group would indicate, and that this is what we're talking about here, is this fascial network, this extracellular matrix. Could that be one of the causes of what we're experiencing in the body? It's not just in the muscle band, but it's in this fascial network. So that's the first one that I think we could kind of dive deeper. You've already brought up kind of this idea of talking about peripheral and central sensitization, but I think the step in between, still thinking like a mechanic, and I like the idea because it bridges the gap for those that are still in that space, saying it's a muscular issue. Okay, well, if we think it's a muscular issue, what innervates those muscles and local tissues? And I always come back to this idea that the same nerves that innervate muscles also innervate the local skin and fascia. So the cutaneous nerves that branch off of those motor nerves. So whatever we're doing to an area of the body is also affecting these cutaneous nerves. And so they bring up this idea of neurogenic inflammation as another theory that we should be discussing as it relates to myofascial trigger points. And so, in my opinion, on that interpretation of what or neurogenic inflammation is basically neuritis. If you want to look at Quintner's paper that you've attached it in there, Quintner is attacking the concept of muscular taut bands, and proposed an idea that these trigger points may not be just in muscles, that we should be considering neuritis or neurogenic inflammation. So that's like my second point of like, let's look, let's broaden the aperture, so then we can start looking at tissues around the area, fascia and also cutaneous nerves. And then lastly, they do a good job of kind of discussing the idea of peripheral and central sensitization. So those are the things that I've been kind of moving more towards, is like what's happening peripherally, that we could talk about end plates, we can talk about stimulation of dorsal root ganglion and that peripheral, mediation of trigger points. And then as we travel upstream to the central nervous system, and this is exactly where I am right now and spending most of my time, is talking about what is that pain experience associated with myofascial trigger points having an effect on the limbic system. What's actually happening centrally that's creating the experience that we all feel. So that's kind of like, if I had to organize myself: soft tissue milieu, extracellular matrix, neurogenic inflammation or neuritis, let's kind of expand the window to nerves, and then peripheral and central sensitization / limbic effects. So that's kind of how, and if I had to track my philosophy in thought and also approaches that I put into my manual therapies, that's the direction that I've taken over the last 20 years. So I thought it was just an interesting experience to read in a paper that followed my philosophy from start to finish.
Are you willing to put a flag in the sand on any one of these, or do you feel like it's a spectrum? So do you feel like they're all playing a part, or
Listen, we're talking about a complex system. There's no way that I'm putting a flag in any of these camps. It is. I'm spraying the environment because depending on the individual, depending on the environment that individual presents, and that it changes the access point that I'm going to be entering in. And so I might pull back all the way to Travell and Simmons of saying, hey, today, my communication to the patient, we're attacking this muscle. Because if that's what you believe to be true, I want to create this synergistic, this therapeutic alliance with the individual, and I don't want to create an added blocker that doesn't need to be there at that time.
Yeah.
So I'm going to attack a tissue that they believe to be, at fault. But this does offer me, or it provides me the opportunity to say, if that approach wasn't favorable, could we discuss, and this is, I'm just speaking to you as if I was speaking to my patient, can we discuss other models of approach that are demonstrating some effectiveness, so that we can start to now, in a again, a synergistic way, attack the problem in a more global fashion.
Okay. So to summarize that, more synergy across approaches with the available theories rather than I'm picking this theory that predominates my treatment modality.
Correct.
Okay. So let's do this if you're game. Let's break down just kind of the mechanisms, proposed mechanisms, a little bit more in depth for each one of those four categories of theories,
Yeah.
but then also use kind of a patient example with a couple different scenarios that would maybe change the intervention or the jump in point based on chronicity and all these things. So
I love it. Love it.
from the tissue standpoint, I think we already kind of talked about, the classic definition that we, the big question here is the Interrater reliability. Like, can you and I feel the same thing? And then would we have the same even intervention point, like literally geographically on the body based on what we're palpating? That's the big question that gets called up. I mean, that even gets called up in Quinter's paper, numerous times. And, Brett Winchester talks about this a lot. I would say, and I'm assuming, I don't want to, put words in your mouth, that as you get better with your hands as a manual therapist, and we could still ask the question, do you need to be hands-on? Well, that gets into a patient specific scenario. That the better you get at palpating, the more reliable that would be between practitioners. I think if we put a brand of somebody in chiropractic school against you, yeah, you're going to get crazy different results. But this is my thing: a trigger point stands out like a red, I don't know, a red bullseye in the middle of a white room. Like, once you felt it, and that may be the thing, once you know what it is, you're like, oh yeah, I can reproducibly feel that. I think it's easier than joint restriction, right? For reproducibly finding, if that's what we want to say, a trigger point. What's your thought on that?
Well, I'm going to echo most of what you just said. It's clear, and you can read enough of the papers that indicate that experience does probably matter to be able to hone the skill of palpation. So it's clear that the accuracy, and Interrater reliability improves as the experience of the individual, increases, and so that makes total sense to me. I think the other part, as it relates to a palpation, and we should just discuss in respect to the subjectivity and the objectivity of what we're really trying to capture here, and maybe, again, discussing, does it really matter? But we do know those that individuals that are experiencing pain, their 2-point discrimination or their ability to actually localize, it becomes compromised. So meaning that, we see cases, and I've seen them a lot in my career, especially as I get more senior. I see more difficult and more chronic persistent pain patients that have demonstrated this, meaning that I go through and do a screen on their touch map, and we can talk about this, moving forward, but looking at their maps of different parts of the body. But if I'm talking about the lower back, I've had people had difficulty identifying if I'm touching the left versus the right side. We're not talking about, am I touching around L1 or L2, like very discrete regions. We're talking about a wide area. And it is known that the lower back larger areas of the body don't have as much discreteness as we do on the tips of our fingers. That being said, having difficulty localizing left to right is a significant alarm that needs to be addressed, because the individual and their nervous system, their brain, is having difficulty understanding where this body part is in space, and that is a threat to the nervous system when you can't feel. So if we're using our senses, the therapist's senses, to be able to locate an area, that's one component, but we're also looking for subjective input from the patient. So that is complicated because of the fact that their ability to actually identify the local area might be compromised. Let's say that.
Yeah.
So I think we do need to recognize, at the very least, just recognize that the palpation and location of these quote unquote trigger points isn't as accurate as we would like to be. And that is part of the controversy, saying, if, well, you can't find it, then how do you treat it? I take a step back from there and say that we're talking about a more complex system. So let's understand that there may not be as much accuracy in the location, but we can start to use that as a guide, and we start working from that region, not necessarily from that point. And that's how I just talk about this idea of the neighborhood. Let's get to the right neighborhood. If it's the lower back, I'm going to start to bring attention to the lower back, a pretty wide spotlight. I'm talking about a hands-on technique. I'm using a wide spotlight. I'm going to treat the region, the neighborhood, and then we'll get closer and closer to your specific coordinates that we need to address. So let's start with that, is that recognition that there's some variability in our ability to palpate, as well as the subjectivity of the experience from the individual. But we are getting into, and I think it's an appropriate time for us to discuss, we're getting into a really exciting time in history, is that the technology is starting to catch up. And so we're starting to get some indication that we could use technologies like, and so let's kind of just list the ones that at least I know. MSK ultrasound, this, Beau, and I've been sharing this in my education for the last 10 years at least, is taking advantage of a technology that's traditionally used as primarily a diagnostic tool. So we're using an MSK ultrasound to identify tissue tears and true stark trauma to the tissue. We could now start to use the same technology to actually evaluate different layers of tissue to identify what may or may not be a trigger point. And so MSK ultrasound has been kind of one of the first technologies to start the process of objectifying, can we locate a trigger point or an area that is identified as a trigger point. So they're starting to identify that using MSK ultrasound, areas that are thought to have a trigger point will demonstrate an area of irregularity, meaning that the screen of that tissue is just, it's not as consistent as other normal tissue. I'll use that in quotation. And there's also an area of what they call hypoechogenicity, meaning it's just darker, which could indicate a bunch of different things. Inflammation can look like that. So we're starting to get some idea, without getting into the weeds, is that MSK ultrasound can start to potentially locate, those specific coordinates of where a trigger point is. And in what layer of tissue we're talking about. Is it the muscle, like we traditionally think? Or is it in the neighborhood of the fascia around it, which we could discuss, which you can visualize with MSK ultrasound? Is it in the subdermal layer, between the skin and the connective tissue that we're talking about? So MSK ultrasound is one that we should talk about. The expansion of that would be, some would call magnetic resonance elastography, some call shear wave elastography. Elastography is, for those that don't know, I just consider it MSK ultrasound with extra bells and whistles. It's got some software ability to be able to look at tissue stiffness. Is probably the best way that I can describe it. Is depending on the information that bounces back from the unit, it can provide insights on the stiffness of tissue. Is a discussion we should be having as well. So that can also help to organize where the true dysfunctional tissue is. And the other ones that I'd like to kind of bring to your listeners' attention, and I think we just need to know what the evidence is telling us, is that there are some technologies that are starting to be developed. They're not great yet. I'm not sure if I even have one in front of me. I do, actually, because I have every tool to man, because I'm a gadget guy and I like to see what's available. I'm assuming you can see me right on screen.
Yeah. Yep.
So this is a device, and I'm not trying to sell this device. Actually, to be honest, I feel this device is still a little bit early as it relates to what it could provide. But this is a company that I found just by chance, to be honest, and it's a company called the Pact, Pact, pactsense.com. I think is the maybe it's thepact.com. I can put it in, we can put it in the show notes moving forward. But I think it's an interesting technology where this is a device that is placed on X tissue, let's say the area of the body, like the neighborhood, if we're going to use that. And what this device does is it emits what they call an acoustic wave, similar to what MSK ultrasound can do, is that this applies a sound wave or acoustic wave that bounces off tissue and it provides information, as we discussed. This one is starting to now take that information of how the acoustic waves bounce off of different layers of tissue to provide information on stiffness and damping of the tissue. So it gives you an idea: is the tissue supple and flexible? Does it have the ability to absorb, stresses versus not? The only problem with this device, as we stand, and we're talking about this in March of 2024, and I want to make sure that folks that listen to this down the road, this technology is advancing. And so the reliability of this, and it really comes down to the user, training, is how comfortable are you using a device to be able to standardize the information. We're starting to get some evidence that we can get better with technology like this. So this is the one that is using acoustic waves to be able to provide insights that we've learned from elastography to kind of give you a sense of tissue stiffness. So that's exciting that we're getting to a point where we can objectify. And then my last one, as it relates to, long-winded answer to your initial question on, reliability and sensitivity, is taking advantage of technology like MRI technology, magnetic resonance. And Stecco published a paper, this is probably 2017, but looking at a therapeutic intervention, their fascial manipulation for the elbow, but they used a method of screening called T1Q mapping, which is basically an MR technology that allows you to identify the amount of glycoaminoglycan, like the certain ingredients in the fluid network of this neighborhood that muscles live in. How bound to water is it? And the reason this is important is that it kind of gives you an idea of the tissue stiffness in an area using this technology. So to sum up, there are ultimately 4 objective ways that we're starting to get some evidence on: basic MSK ultrasound, shear wave elastography, which is just ultrasound, with added software, some technology, some handheld devices like the Pact that's starting to kind of enter into the industry that allow us to use a handheld device that's affordable to be able to capture the idea of how stiff tissue is. And then the T1Q mapping, in my opinion, is kind of new technology that to identify what's this fluid network that these tissues are all bathed in, and is it a good lubricant or not?
Yeah. Well, and 2 sentiments on that is Rich Olm kind of tells a story when he teaches that for a long time, if somebody had an MRI prior to come and see them for lumbar spine issues, he would, and because a lot of times I don't want to see the image, I don't want to see the report until I've done an exam because you don't want to be biased. But he did the reverse for a while. He would look at the image while he was palpating and see if he could just match like what he was feeling on palpation, and any changes. That's what I want to also make sure is like the easiest access, even though it may not have the most reliable, inner and intra reliable. rateability is still palpation. So maybe we use these technologies to test ourselves against that, both in a research standpoint, but or in practice. Like the Pact is a perfect example of something that's easy, accessible, not super expensive, that you could start to learn like, oh, what I'm feeling has this presentation on this device. The one I did want to dive into, because this will walk us into the chemical milieu, but then that takes us into the central and peripheral sensitization talk,
Yeah.
is the, the T1Q or T1 row mapping that, you mentioned what it's looking at, but one of the main things it's picking up is hyaluronan within these tissues, which
Yeah.
the more I read on this, and I sent you another article, this was an old article from 2011, just talking about hyaluronan as an immune regulator in human diseases. And you just look at this. And again, this is one of those things you're like, well, wait a minute. If something's this prevalent in all pathologies, that's what it looks like, right? There's things that it sticks out more, arthritis, a lot of things around the lung field, a lot of things that are associated with some sort of fibrosis taking place in tissue, which plays hand in hand with, what we're talking about. That this became more and more prevalent of like, not necessarily like there would be more present, sometimes there would be less present in some pathologies, but it looked like the movement of it, which sounded eerily similar to like chi or ki. What you talk about Eastern medicine, like if anybody's read The Body Electric, they really talk about morphogens and like they're basically trying to create a bridge of, okay, Eastern medicine talks about it like this, Western medicine talks about it like this. Both are right. It's just dialectically different. And I think that's sometimes what we're trying to do is explain what's happening in our treatment rooms via science. And, if we had to kind of track back, 5,000 years and be like, hey, is this one of the things we're looking at? Maybe. I don't know. It just seemed very interesting to me, a lot of the parallels. Because again, as we know, like with arthritic pain, that's immunomodulated pain. So then that plays into this hyaluronan thing. So it's like, well, can we again suss it down to we're going to just be seeking and destroying this one thing via, T1 mapping or, whatever? Maybe, maybe not. But like you said, this is the why. This is why we're asking these questions, because if we can get more specific and precise, treatment outcomes become better. And in the face of an impending, musculoskeletal burden on the US and the world, we'd hope that our results get better, which they're not currently.
Yeah.
It's getting worse.
Well, you're right. They're not. And so it it bodes well that we're at least having these types of conversations to say, okay, if the culprit that we've been attacking for decades, addressing the muscular dysfunction isn't creating the long lasting changes. And that's again important, the long lasting changes. I was very effective short term. And this is where I somewhat feel ashamed sometimes if I have to think about it. I'm a lot more self-compassionate, and I start to recognize, hey, I did what I knew at
Yeah.
the time. I follow Gray Cook's ideas that I did what I knew at the time, and now that I know better, I do something different. And so I love that idea is that he did basically would keep telling us, I'm telling you what I know now. When I know more, I'll tell you. And I love that idea because as I kept saying at the beginning, I was the mechanic focusing my attention on the muscle. So this idea of the soft tissue milieu is, I think, what we're talking about now, getting into this extracellular matrix, the neighborhood that muscles live in. So it's not too far of a leap away from where a lot of people are, that they're so tied to the myofascial trigger point. It's like, that's fine. Let's stay in the neighborhood. Let's talk about the neighborhood that those muscles live in, this extracellular matrix, the fascia, the fascia. And I'm going to use different terms for us to discuss, but this matrix, and just over the last probably 6 or 7 years ago, this new organ, if you recall, this new organ that was discovered just because of new techniques in pathology, is this new organ called the interstitium. Do you remember the interstitium discussion?
Mm-hmm.
So I love the interstitium discussion because it's not a new organ. Obviously, it's the same organs that we've been living in, our whole lives. But now we better understand this organ, this network, this neighborhood tissue that muscles live in, is fluid filled, meaning that this network of tissue is primarily more extracellular matrix, which is just loose connective tissue fluid. And in that fluid resides and I'm just using terms that I use to kind of explain it to even my patients, saying there's an ingredient in this fluid network that either will improve your ability for those tissues to move, which is important for all the mobility that we need, or restrict your mobility. So, depending on the quantity and quality of hyaluron, this ingredient that I'm referring to in this water milieu, um, it will change the way that tissues can slide and glide. So, uh, again, it's important for folks to really see this and almost take that extra wide view of the human body. It's not muscles, but it's muscle is just one of the tissues that has to be able to slide and glide to be able to give you the range of motion that you need to be able to perform meaningful movement. So that there's muscles, there's fascia or connective tissue, there's the skin. So all these layers of tissue, and I use my hands like this all the time, that these tissues need to be able to slide and glide amongst each other. So what provides that lubricant that allows tissues to slide and glide, ultimately what we're learning is this hyaluron, this hyaluronic acid, this glycoaminoglycan that can actually assist mobility or slide and glide, and it can also resist depending on the amount of it. So if it accumulates, and this is coming right from Stecco's mouth, as hyaluron accumulates or aggregates, it actually can restrict range of motion. So there's like a sweet spot of what we're trying to achieve to be able to improve slide and glide. And interesting enough, manual therapy, traditional stuff that we've all been trained to do, compression and stretching of tissue side to side. And think about what I'm doing with my thumb. It's almost looking like a lot of the therapies that we've been taught, from hands-on techniques to instrument-assisted techniques, that compression and shear, movement and temperature is the four things that Stecco would talk about. Compression, shear or lateral stretch, movement, body movement, as well as temperature, has been shown to improve this ingredient that we're discussing, hyaluron, to improve the quantity and quality of this ingredient that improves the lubrication of our tissues. So I'll stop there and see if you have any questions on that.
Well, I was just going to say, I think you need to trademark your dance move and call it the Italian DJ, because it seems very fitting to use your hands in that manner. But, yeah, so we're talking, okay, we've beat the horse, maybe not completely, of hyaluron and, some of these issues, but there's some other things that are consistently seen, even though there may be conjecture on, well, what's that mean? But you see excess acetylcholine release, right, at the end plate, which you mentioned, end plate, uptick in activity. And then maybe it's the inability to clear acetylcholine. That's kind of the thing that's talked about. Well, is it more released or inability to clear it? So there's, some local things. We also see increased catecholamines, and kind of a normal inflammatory cascade, cytokines, things like that. You just like if you sprained your ankle, right? We see some of those present. I think some of that's going to be dependent on the chronicity, right? I mean, I'm sure you've seen, like I have. Like we had a guy that came in the other day. He literally hit it, like tripped on a route trail running. The cause of his massive glute pain, in my opinion, was a trigger point. It was nothing more than that, and that was like a trigger point that, locked on. I mean, that's acute. Maybe that has a different. I mean, he had mild swelling, but that was a trigger point. I mean, there was no other, central neurologic disruption. Not a major tendon issue. We actually did this case on the week in review. But then that local Milieu, we know now, is having an effect, which leads us into this, peripheral sensitization. So we see that as we have this consistent kind of chemical presentation and also this nociceptive loop, that now this muscle or this tissue, let's say the neighborhood, is sending a consistent signal, whether it's being used or not. That becomes the big part of the equation now. Now we start to see that we're starting to smash, the WDR, the wide dynamic range portion of the dorsal horn with substance P and, things that are going to uptick. And then this is because the reason I dove into Shaw, if I'm being honest, was I have massive questions about what starts central sensitization, right? Yeah. Is it you have something central going on and then you get an injury in the periphery, or you have something in the periphery that ticks up the central? This didn't really define that for me, but it gave me more ideas of maybe a lot of this is happening in the periphery, that it's not necessarily you have some sort of derangement in your lumbar spine, and then because you're moving a certain way around your knee or ankle, okay, now it hurts. Well, no, like you could just have it for, you have a very healthy lumbar spine, but I think it happens both ways. That's kind of a side thing. But in this sensitization pathway, I mean, this is talked about all the time now that people are sensitized. There's peripheral sensitization. Phil Snell talks about this, in the periphery with all of the things that he's using to kind of affect more of the cutaneous nerves. What is this as clinicians? Why does understanding this, where does this lead us from a treatment standpoint? Because that's the reason we're asking all these questions is like, yeah, we want to be better at assessing and understand, but like, okay, if we know the physical, right? We know the physical has this manifestation that's both chemical and in physical presentation. We know that we just talked about the 4 concepts that Stecco highlights of those who are playing into treatment. Now, from a sensitization standpoint, does that change what we're doing based on what's going on, or if we can pick up something from a assessment standpoint?
Yeah, man, listen, we're trying to detangle this nest, this web,
Yeah.
and we started the discussion of talking about muscles and moved on to the neighborhood of fascia or connective tissue, and so I'm going to use that as kind of my uh, launch board, if you will, as it relates to talking about sensitization. And I think Stecco does a good job of communicating this. And again, using my DJ concept is that I love the idea, and this is just going to extend the conversation of hyaluron a little bit more, is that if we're having this lack of slide and glide of tissues, I think it's important because now once we start to identify what tissues that we think is causing the trigger point, and so now we're starting to open the aperture to think not just muscle, but maybe the tissue above the muscle, tissues above the muscle. So how this changes my manual therapy approach is immediately changes my depth. So this is important, is that this is where I do think it matters what we do with our hands, is that I can change the amount of compression, the amount of shear depending on what I'm trying to achieve. And I feel pretty confident in saying this because I've spent the last decade of really taking MSK ultrasound that gives me real-time information of what's actually happening underneath the tissue to identify what happens when I go like 3 or 4 in depth out of 10 versus 7 or 8 out of depth in depth. And so understanding that it could be the neighborhood tissue, it allows me to back away and I can intervene with this idea of compression and shear movement and increasing temperature. And then we can assess both subjectively and now even objectively with some of the tools that we talked about. Did I make any change to those tissues that I feel that are involved, the neighborhood tissues? If I did, I should also notice, and this is what we all see as patients and we've seen in our patients, is that they see a relatively immediate change in their pain expression. So locally, peripherally, we can talk about what Stecco talks about. If the tissues are stuck together and there's still movement occurring in the body, that friction, that lack of glide and slide and glide actually creates that overstimulation of the nociceptors that reside in this network of tissue, which again is important for your listeners to really understand. The fascial system is not just the bag, right? And I can't believe I'm still saying this in 2024, but this network of tissue is as a perceptual network. It's an organ that's highly innervated, if not 5 to 10 times more innervated than the local muscles, tendons, and ligaments. So we're talking about a network of tissue highly layered by mechano and nociceptors. So when those tissues can't slide and glide because of a lack of hyaluron or a lack of quality and quantity of hyaluron, there's limitation in those tissues to slide and glide, stimulating the nociceptors, creating that bombardment of the local peripheral structures, end plates included, DRGs as well, as we discussed. So on the bottom up approach of this idea of sensitization, the lack of slide and glide of neighborhood tissues, soft tissue milieu, can actually start the process of sensitizing the peripheral structures. So that's the bottom up approach, is that if we continually stimulate these danger receptors, these nociceptors, that information is going to be sent locally as well as now moving more centrally. So that could be a discussion we have, is like, how does that bottom up affect the central nervous system and our response to either assist or inhibit the symptoms? And is there something else playing from top down, which is a part of the discussion I'd like for us to continue to discuss as well.
Yeah, and the thing that I kind of skipped over, because I mean, tell me if I'm off base on this. The explanation that you and I just gave on what's happening in the periphery over time literally is neurogenic inflammation. So this is the thought process of the simple way I explain it to whether it's an intern or a patient sometimes, because believe it or not, Alex, our clinician, had a perfect example of this. And I love saying this word, but your weenus, the skin over your elbow, that's the literal term. He came in one day and that it was swollen in the skin. We're not talking bursal. It was swollen here. It was literally hot. And this was sensitive, the skin, not the underlying bone. Um, and he comes in, he's like, what the hell? He goes, I didn't do anything. I didn't do anything on my elbows. Like, what's going on? And we just go up to, the lateral head of his tricep, massive trigger point, twitch response, not really referral into his elbow, but I go, if this has been doing this for a long time, to whatever it's doing, helping you stabilize your shoulder, I don't know, explain that in a different light. But I go, that is neurogenic inflammation. And then lo and behold, you treat the trigger point, you go about it, and then that gets better and better and better, because this was a perfect example why. There's no other explanation why your skin is sensitive. You have swelling in the skin with literal signs of inflammation, heat and swelling, without trauma or anything else going on systemically. That is very important to know, because I've brought this up with other clinicians or interns, which are extremely bright nowadays, and the thought process that you can have literal signs of inflammation, in particular around a joint, say our knee, right, where we're trying to rule out internal derangements and pathologies, that you can have a presentation of inflammation that has nothing to do with pathway anatomical damage. And I think that's hard to reconcile coming from a traditional school, teaching standpoint, that you have to kind of suss these out based on your entire assessment. So I kind of skipped over that. I wanted to make sure that, the tissue neighborhood, the neurogenic plays into peripheral sensitization, or it basically is. And now we can go that kind of, bottom up into the central. And we've already mentioned that, you kind of start basically pegging the dorsal horn more. And then there's a couple things that happen with that, which you can dive into this, but you see that you have actual changes in the dorsal horn, right? And what it's more receptive to, which then creates changes at the ventral horn in output. So you see changes in movement, both from, that could be strength to actual motor control. When you see those things, again, some of the things that we may be looking at on assessment, right? Whether that's movement quality, tone in a muscle. Now you might start thinking, okay, and we could start talking about the patient examples. Did that guy trip on a stump 3 days ago? Or has somebody been dealing with hip pain for 6 months? And now, not immediately, but maybe you're like, man, these are two wildly different approaches. Maybe they kind of look the same 4 or 5 visits in, but those first few visits might look wildly different, even though they're kind of dancing around the same issue. So from the bottom up, what's the take on, well, what do we do with that, I guess? So if somebody is essentially sensitized, we can work in the periphery, and we know that may help what? Like you said, get tissue sliding, so there's less of this nociceptive input that's occurring in the periphery, banging into the dorsal horn. But how do we actually change? The dorsal horns had physiologic change. So how do we work on that?
I don't know if I have a discrete answer, but I mean, I love the discussion, and giving patient examples is important. I think it's important for this discussion as it relates to the weenus, which is something that I have not used that term in a long time. But I mean, that I don't want to skip over this. Just like you said, hey, you think you might have leapfrogged over the idea of peripheral and maybe neurogenic inflammation, is that this idea of cutaneous nerves. So the reason I want to bring this to into the discussion is that we talked about muscles being the initial culprit of trigger points. And then we talked about the neighborhood of connective tissue or fascia. But I don't want us to forget, through this network of tissue of connective tissue, there's multiple exit points for these cutaneous nerves that allow us to feel from the skin level. So when you talk about that layer of symptomology at the skin level, the reason that this is important is that I also would identify these, and according to Shaw, they would propose this to be a concept that we should discuss, is that cutaneous nerve entrapments, a la Phil's work when it comes to his system, Diane Jacobs when it looks at the dermoneuromodulation, DNN, excuse me. So that's these are individuals that I think you should seek and learn from, both looking at a very superficial method of manual therapy. And this is, again, important because it now titrates the depth and level of tissue that I feel that I'm interacting with. And so it's not just always an elbow on a trigger point or a thumb. It might be just finger pads. It might be a cotton swab. It might be something a lot less aggressive. And this allows us to broaden the tools that we have available, because it's not the tool, it's how we use these tools to be able to interact with the individual. So we basically say, if you think it's muscle, we have this depth of tissue, it's going to require this depth of interaction. The connective tissue or fascia is going to take this to be able to influence that hyaluron and the slide and glide. Cutaneous nerves is another layer, even for closer to the skin, that we need to address as well. So I don't want us to forget about that. All of it is true. We're looking at improving the slide and glide of connective tissue, fibrous tissue, and then even nerves within those tissues that we're talking about cutaneous, to be able to decrease that nociceptive barrage to the peripheral structures. So I'm going to get into that discussion, or at least my opinion on that discussion is that depending on the individual, how long they've been experiencing this bombardment of nociception or danger signals, it now I'm going to start to take in this information to make a decision. Am I addressing this bottom up to be able to influence the experience, or is there a top down that needs to be discussed here, central mediators that I need to kind of address, because now what that person believes, their experience, the narratives that they've been telling themselves are amplifying the experience centrally from top down. So I'm saying this in more detail because as I start to kind of break the layers and start to treat them peripherally or locally, I'm starting to make some decisions to say, this is not working at the local tissue, at the peripheral, approach. I should start now thinking upstream and thinking about going from top down. Does that make sense to you?
Yeah. Well, I don't think I've bought myself enough notoriety like Joe Rogan to have bathroom breaks built in, but it helps for sure. The other thing is, who was in the original 48 Hours movie? You'll see my point here in a second. Was that?
That's a great question, man.
The reason I'm bringing that up is, while we're both thinking, the 48-hour window, or that 2-day window, is kind of where we see that you have enough time if you have something happen in the periphery where you can start having central sensitization. It's around that time. I mean, it could be shorter or maybe longer, depending on what's going on. As you said, we're starting to see that now we can ring the bell more often, right? Less or more things will be a nociceptive response, or maybe all things, depending on which theory you adhere to. But we also know that now other things, right? Neighborhoods, and this is where the idea of like latent trigger points and satellite trigger points play into the overall trigger point hypothesis, play into central. What I want to kind of differentiate is, and maybe this is a question. So we have central sensitization from a spinal cord level. This says in the Shaw paper that Needham et al. Demonstrated increased limbic system activity in patients with Urbs-Prezius myofascial pain syndromes. But they basically said that they found limbic system involvement in all of these patients, is kind of what you see across the board. Do you think, or is it in the, somewhere in the data, that as soon as we're seeing a spinal cord central sensitization, because I think we need to differentiate these, that you can have change that spinal cord, but does that mean you're having a psycho-emotional or limbic system response to that? Because we know, or what central sensitization is, you don't have to have pain in your wrist to be having central sensitization occurring at your lumbar spine or the spinal cord level. We could, have a very different approach. So do you think you're having an immediate, literally, what do we want to say, cortical level or subcortical level, maybe response when it hits that level, if it's 48 hours or beyond?
Listen, I can't say that I know, but I feel very strongly that, and we're starting to get evidence to support this, is that touch is touch. And so this, going back to what you talked about on Ben Stevens, which the individual I love, he says it right, is that, does it really matter? And but I do feel that there's some nuance in respect to our touch. And so to answer your question, I believe that any amount of touch is a window and an opportunity to open a window both peripherally and neurologically. And we don't have much control of that, because how that touch is interpreted, depending on if I'm coming in with a soft touch, a thumb, an elbow, I'm grunting, I got a bead of sweat coming down my face. All of that is influencing the central, structures, the limbic system, as we discussed, because things are being interpreted through that experience. But if I had to be more focused, my initial intent, and again, this may be proven wrong as we learn more. My initial intent, if I'm talking about someone with a relatively acute or subacute issue, is that I want to decrease that conversation, that danger signal to the dorsal root ganglion and upstream. I want to see if I can make changes at the tissue level to decrease that local conversation, right? That peripheral conversation. So that's just comes down to trying to identify where the limitation is that at the skin level, fascial level, muscular level, or combination of, and I'm going to do some type of intervention. As I'm doing that, my intent is to improve slide and glide, improve all of the components that we've discussed already, to be able to decrease the nociceptive barrage to the dorsal root ganglion, so we can, potentially make some changes to that conversation. That being said, as a holistic therapist, and I think you fall into this camp as well, we can't disregard the other components, other physiological components that we can actually control, and at least start to control with the individual, saying, my gosh, there's a metabolic concern here that we need to discuss. There's other physiological levers, if you will, that we can pull on to be able to influence their response, both locally and centrally. So that's kind of my initial intent, is let's decrease that nociceptive barrage by touch, through education, meaning giving them, these are things that you should be considering in your diet. These are things you should be thinking in respect to your movement. So we're making changes to the system to be able to decrease that barrage, that danger signal to the nervous system. But I can't separate my touch and the influence of all the other physiological mediators of what's actually happening centrally at the limbic system. And so Shah does a great job of talking about, if we continually barrage the WDRs, the wide dynamic range neurons within the dorsal root ganglion, that stimulation moves upstream. It starts to impact what they call the receptive fields. And so this is just going to be adding to the conversation of what you discussed in respect to latent trigger points and satellites. Does that, the field of the experience of pain, both actually what you're feeling and what could be potentially stimulated, it starts to spread. Lorimer Moseley talks about this beautifully, of the spreading of pain is a centrally mediated function, meaning the brain's trying to protect itself, and it'll do so in any way that it can. So I think it's important, bottom up, to see if we can change that conversation to the nervous system. But top down now, the opportunity that I take, my intent when I put my hands on someone, is not just as a mechanic to move, slide and glide, to improve those tissue dynamics, to decrease that local conversation, but I'm using this opportunity to start to present this idea of safety and connection. So if you give me another minute or two, I want to kind of talk about this, and then you can ask some questions that hopefully can clarify. My intent with my hands is, as a mechanic, is to do the things that we just discussed locally. But centrally, I believe, and we're starting to get some more evidence to support this, is that how I approach this, the room that I do it in, the temperature of that room, how I communicate what I'm going to do, the softness that I approach, or in respect to the opposite end of the spectrum, the amount of pressure that I apply, all of this matters because now I'm starting to have a connection or a conversation with the limbic system, the insula, anterior cingulate, and other structures within the limbic system, including the thalamus, to be able to see if I could use this opportunity of touch, not to mechanically manipulate anything, but to change the narrative, to change the conversation that someone's providing to the system centrally from top down. I think this is where I am right now, kind of going full circle to where I am now, where I focus most of my attention is how do I train the therapist that I get to, lecture to, how do I get them to start to understand that your touch is a megaphone to the nervous system? It's an opportunity to be able to change that narrative and conversation top down.
Yeah, which I love, and I hate to bring a shade of negativity, but one of my biggest pet peeves, and I'm saying this, I'm saying new students, interns, because they're just new out of school, and that's where I see it the most is when we have people shadow. Is we'll get done with like a patient interaction or something, and maybe they see that I didn't do a whole lot of like hands-on, whether that's because it was later in care, and that's usually the kind of the triage, or it's a different type of patient, but they'll go, "Oh, is that more of like a BPS patient?" And I'm like,
Yeah,
you're literally calling it a BPS patient, which is kind of encompassing a human, right? The biopsychosocial. It
sure.
drives me nuts because it's like, well, they are thinking you're either hands-on manipulation, soft tissue, or chronic pain. And what we're trying to maybe messily or eloquently, depending on who's listening, and if our moms are listening, gonna give us a pat on the back, is like it's always all of that. It's depending on the spectrum and how much of what you use, what you say, like you said, the temperature of the room, like all these things matter. And the best in the world is, Brett Winchester's talk now is kind of the it factor. Like, what are the other things? And he's saying the it factor from, clinical success, but treatment success, which sets up clinical success. And that's what we're kind of getting at the root of, which is kind of funny that everything spins back to how you approach it, not just the technicality of it, but if you're going to do ART, how you do ART, how you explain it, how you approach them. So that I kind of had a couple dive off points. I want to back up for a second because you kind of said about Lorimer Moseley and kind of the spreading of pain, right? As we have this central phenomena. But one of the more interesting things with trigger points is the succinct referral patterns that were, really detailed by Travell and Simons that are reproducible. I mean, I'm sure you've had you're like, oh man, that, gluten refers right where we thought it would to the SI or whatever it is.
Right.
And that's what was interesting in Shaw's paper is the supposed explanation is central sensitization. That is, you have more impact. That maybe the way that you're, bombarding the spinothalamic tract and how that then changes ventral output, which then regulates, a movement, creates pain. And it was super interesting because that's my biggest thing is like, well, what the hell? We understand why, radiculopathy occurs. Like we can trace a nerve anatomically, but then to have this kind of like magical referral pattern is like, what the hell's going on? That is,
Yeah.
fairly reproducible. So that's one thing I wanted, the listeners to hear is there are ideas behind that. And that's one of the reasons that trigger points get beat up so much is that, oh, you're going to push on your anterior scalene and that's causing your wrist pain. And we're going to go treat this thing. And like, which brings me to the wild card in this whole, we've walked down the tissue, the neighborhood, the neurogenic, the sensitization, throwing in the BPS, the psycho-emotional part of the entire mechanism. But then you see maybe not an approach or a theory, but something like DNS, right? At the heart of DNS or dynamic neuromuscular stabilization are audits or these things we're pulling out from assessment like trigger points. That's a huge one that comes largely from Levitt. But you see very little hands-on work on the trigger point itself, right? If any. I mean, you get some, and now, it's Stecco is being introduced more and more and things like that for sure. But you see massive improvement And again, improvement now is based on, did that thing exist in the assessment that came before it, with no touch, right? No physical hands-on improvement in slide and glide, but we see the concepts behind DNS or a neurophysiologic presentation. As Pavel would say, hey, the trigger point doesn't exist in your muscle, it exists in your mind, or the cortex, maybe a more appropriate way to put it. But then we think, okay, what's happening there? We know that we're trying to flip the pull of the muscle, get a big eccentric load, which obviously, if we're looking at fluid gradients, maybe that's changing, the fluid dynamic in a muscle or tissue. So what's that, how's that register if we're like, hey, our touch is important. Yeah, you're still touching people with DNS. It's just not on the spot usually. And then we see such great effects. Again, what I'm always trying to decide is what's the best intervention for the patient. So is it that we shouldn't be working on anybody's trigger point because we can actually get to it this way that is encompassing motor control and, neurophysiologic response and, bigger movements and how you load the system versus, well, hey, I can get the tissue moving and then I can be, specific with what tissue I'm aiming at or, around that area. Then I can kind of work on integration of that movement to decrease the central provocation. Again, I'm not saying there's a right or a wrong, but is there a way that we're like, where do we lean? Is that patient dependent? Can we pick that up in assessment? Like, where do we go?
Uh, this is a beautiful, maybe ending for our discussion because we can talk about this for hours, which I'm totally game for. Just FYI, and maybe we'll do these in parts, and just making sure that we're adding value to the discussion to the listeners because, as you said, sometimes conversations like this can make entangle the conversation even more, meaning, and that's not the intent. Obviously, we're trying to, at least through our respective experience, to kind of demonstrate how we kind of tackle this type of complexity. So to answer your question, how I decide, and your way of describing the non-touch versus touch modalities that exist that are showing effectiveness, like DNS, I'm a huge believer. And in fact, I focused my attention when I did my DNS training on the exercise track because I felt that I had enough training, and that's with all due respect in the industry, that I felt my hands-on techniques, I have the tools to be able to interact with the body through that type of manual approach. I was looking for an approach that took movement or motion in the body to be able to influence the same parameters that we're talking about, from muscle tissue to fascial tissue to nerve glide, peripheral and central sensitization. All of that can be impacted through a touch tool for someone outside in, and it also can be impacted through your own movement. And that, I truly believe that this to be true. So how do we decide with the individual that's on a table or in our treatment room? How do we decide how we're going to interact with them? And my philosophy on this is that it's a therapeutic alliance. I'm going to capture or collect as much information to make a decision. Is this person going to respond more favorably to a manual technique or a movement technique or a combination of? And so the ways that I've been doing this to share with your listeners is that I'll do some objective screening. I used to just ask questions, which is still reasonable if you're not willing to use some of these objective tools that I'm going to suggest. But it's asking the questions and getting insight to say, is this person going to respond positively or negatively to my hands on their body? Right. So that's important. So some of the things that I do to kind of make a decision on, do I want to touch them or not, is that I might use something like the Tampa scale or the FABQ, the fear avoidance behavior questionnaires, to kind of identify what does someone believe in respect to what's happening to their body, coupled with other questions that we can do in our typical initial histories to be able to kind of get a picture of the individual, to say this person's going to probably tolerate and respond more favorably to a hands-on technique because of what they believe and what they fear and what they're seeking. So those are all the things that I use to make a decision on what I'm going to use. But as I progress the individual, the ultimate goal, and this is part of the polarity in our conversation in respect to using manual therapy or not, You can talk about this, throwing another name into the bucket, Adam Meakin, saying that any of us that are putting hands on people are completely ridiculous. And I respect the individual for, what he's trying to achieve, because ultimately, polarity existing in the industry, I hope, let's say this, that we're all wanting the best thing for our patients, right? I think me putting my hands on someone, I'm not thinking maliciously saying, I want this person to see me for the rest of their life. I'm doing it because I truly believe that there's an effect. And I'm using the models that we discussed today to make sure that as closely as I can, I'm addressing the appropriate tissues to be able to influence the tissue as well as the nervous system. So I feel very comfortable with that. But Meekins and the rest of that community would say, well, movement can do the same thing. And I would not argue this, but the point is that a patient is an individual, and that person may not be prepared to accept the fact or be in the position to move their body in a way that's going to provide that curative effect that we're looking for. So I feel that you can tackle it from both sides, but as a general rule, it's all lumped into one, and we're making decisions on a day-to-day basis, depending on the person's ability to actually implement.
When I think we can take your sentiments back to the beginning, before I do that, just my 2 cents on the polarization. We see this, even Craig Liebenson now kind of fits into that paradigm of like, well, hey, let's be hands off. And I think from Craig, I don't, again, we could have him on the podcast, but he's looking more of at a population bias of what's going on. Like, yeah, we have people that don't move as much are generally unhealthy, so they need more movement. But my thing that I always tell students when I see that they're leaning more into this hands off, whoa, what are we doing? Soft tissue adjusting our patients is what are you going to do when you get a world-class mover, a gymnast or somebody, and we think that this generalized movement approach of like deload and reload is literally what they're doing for 40 hours a week. And I think when you get to I mean, it's N equals one, and you get to a performance level, there's a reason that every pro athlete in the world has a physio. It's not just because they like getting a massage. It literally has, whatever we're going to say effect is occurring, right? Maybe it's a huge emotional effect. There's something going on there where if we just said we're going to train them differently, in my opinion, I just don't think it's going to work quite the same. That would be my 2 cents on that, to kind of echo what you're saying.
It's great.
But to go back to the beginning, when you were saying, hey, when our fundamentalist kind of upbringings from Cairo school of, hey, here's a tissue, here's a joint restriction, attack, that is a much clearer message to you as a clinician, but really to the patient, right? So the understanding, the therapeutic alliance is probably stronger with that approach for most people because it's much easier to convey the message. Which I just put a post up a couple of days ago against clarity versus conjecture. So what I wanted to kind of wrap up with, this is not to create, well, it is to create more conjecture, to eventually create clarity. You need to talk about these ideas with colleagues, people that understand things differently than you. Because if we don't understand something fully, I mean, you're not going to get anywhere, which we could bring that back to the political, talk. Like if you muffle certain things, that's not great, right? You have to
Who's the victim here in this conversation in respect to polarities and views, and not able to kind of meet in the middle to discuss that we're talking about a human being? Who's the victim? It's the patient, right? Who's the victim in respect to politics? It's the people, right? So that we keep coming back to this discussion, and this is this is another tangent that we should discuss. But you brought up some names. I brought up some names. I'd love to get in a room, and I mean, this is the real thing that I want us to do, and maybe something we can kind of tackle together. Let's get Liebenson. Let's get Meekins. Let's get we can talk about. Let's get Winchester. Let's get the group, the minds that we feel that are going to be at least open to the conversation. So let's have this discussion in a cordial and a manner that's going to provide some productive solutions for the patient to take advantage of. Because again, the victim is the patient. When there's this much of confusion and conjecture on both sides of the fence, then they don't necessarily which way do I go? And should I go to the exercise route? Should I go to the manual therapy? Who do I go to? And it really depends on, in my opinion, it depends on so many different variables that the therapist, the one that's really leading the beginning of this therapeutic alliance, is to say we're going to make a decision according to a lot of information.
Mm-hmm.
And once you have that information, you can kind of lean one way or the other, which may change from day to day, which is completely normal. And I think we should, if we accept that, me putting my hand on someone to influence either tissue or the nervous system or both, coupled with movement, is exactly how I've basically treated for 20 some odd years. Now I'm just starting to better understand what I'm trying to achieve.
Yeah.
So I think the opportunity is here. We just need to have more of these types of discussions so that we can create a message that makes some sense to the people that matter, which are the patients and clients.
Yeah, I say we call it the MSK powwow. That's it. And yeah, I think that needs to happen because and we'll wrap it up on this. I think, as you said, people that have a decent, amount of bandwidth in the public eye, that's who people are going to be kind of like, they create a tribe within that, and then they become just like diet, right? Tribalistic, and like, well, this is how it happens until it doesn't. And then it's like, well, that can be defeating. And like, some people, you're creating a worse scenario for yourself, which brings it back to the heart of something that is, like, this is my kind of why, is like, I want to help create world-class diagnosticians. I think that's what this gets back to, is not necessarily just the technical diagnostics, but the soft skills, talking to somebody, figuring out what's going on, behind the curtain. When you get better at that, I think all tools are necessary, and you just have to decide which one to pull. Which, what we would love, I think what you're saying, is the conversation of people that are emphatic about their tool or their methodology is the best. Well, now we have to ask the question of why. And you have to substantiate, okay, is it a panaceic approach to, yeah, that's what the best for everybody, or maybe it's not. That's what people aren't willing to hear, because that's not polarizing. It's not clickbaity. It's not gonna,
Right.
it is a conversation like this. And not that I'm anywhere going to ever be anywhere near him, but that's why Joe Rogan, somebody as so successful as him, open-minded, long-form conversation, and not going to shut much of anything down, if it's substantiated by at least a little bit of data or science. So I think that's where we need to push the profession. And I mean, I see you as one of the leaders in our profession for sure, because of your demeanor, your body of knowledge, but then also your creativity of thinking, that you can take ideas and still spin them, instead of being so adherent that you kind of die by the literature, which I think is just kind of, it's going to happen to some people. So I want to thank
Yeah.
you for being on this call. I know it's been, the third one on our official show. You and I have had a lot of conversations like this, and I could literally talk about this stuff all day, because it's, when you talk to patients about this all day, it's like you can't go to this depth. You're never going to go to this depth. You want to tell them everything, because you just want them to have the best information. But we need more of these conversations to also create clarity with the message, once we determine like what our best interventions, assessments, all that. So we all not necessarily are saying the same thing, but that it's not somebody goes to Capo and here's a wildly different chiropractic story than when they come to see me.
Yeah. Yeah, and this is exactly the point, is the communication. We've been talking a lot about communication via touch and through movement. I think those are important. And I created a brand around this idea that movement matters. And I truly continue to believe that, regardless if it's hands-on techniques or moving the body through space. But my point is that communication, the ability for us to distill a paper like Shaw, which I would definitely challenge anyone that's in this space to read through this one and do the same thing that we did, is highlight and sticker it and post post note it and do all the things you need to kind of discern all the information that comes out of it and make an informed decision, and then start to craft the art. You called it soft skill, but I call it art, of communicating this to the person that matters, which is the person that we serve. So I mean, this is such a great opportunity. I love you even giving me the platform to be able to have the opportunity to kind of tell you what I think is in at least my front view,
Mm-hmm.
knowing that pathway is going to change multiple times in the next few years, and that this is what makes this such an exciting time, is that we're going to know more, and when we know more, we get to have these discussions again to tell what we know.
Hmm. Well, so what Capo is leaving out is look for MSK Powwow 2025, location yet to be determined, and the roundtable yet to be determined. But yeah, I would love to see something like that happen. So let's keep that conversation going. And thank you again, man. I just can't say thank you enough. So for everything.
Pleasure. Yeah, it's a great opportunity. I appreciate the discussion.
Thanks, man.
All right, bud. Have a great